Dear students, today we'll discuss a case scenario which is very common. We will come across in day-to-day surgical practice. Just see what this condition is. Look at this. Look at this. Breast, you can see that breast here. Almost nipple areola is distracted here. There is a lump here also probably. And skin nodules are there. See that skin nodules? Skin nodules are there. So everything, you can see that skin involvement, destruction of the nipple areola. Areola also involved. There is probably a lump here. Lump may be extending here in the lower quadrant. Upper quadrant looks normal. And see that it's a very typical of the first possibility you have to think of is carcinoma of the breast. Of course, you have to examine the axillary lymph nodes. You should know how to examine the axillary lymph node, anterior, central, apical, lateral, and posterior and supraclavicular. And also, what you have to examine the breast also, three muscles are important. That is pectoralis major muscle, how to check, latissimus dorsi muscle, how to check, and serratus anterior muscle, how to check. So these are the three muscles. Chest wall involvement also you have to check by breast which is not falling forward, means chest wall is involved. And axillary lymph nodes, opposite breast, opposite axilla, supraclavicular lymph nodes, and systemic examination, mainly spine with the movements, spine tenderness, paraspinal spasm, rotation movement, which is very, very important. You have to do it in sitting position. Then abdomen examination for liver and ascites, and longest respiratory system for effusion and altered breast sounds. So the basic things you have to look for in any carcinoma breast. Local examination is very, very important. Detailed history also very, very important. And you need to remember some differential diagnosis. Very unlikely this breast lump, look at that, it is definitely carcinoma of the breast. Naturally, because kidney nodules are there, has to be advanced carcinoma of the breast. Of course, tuberculosis may be a differential diagnosis. Granulomatous mastitis is not uncommon. We will come across in day-to-day surgical practice. These also should be kept in mind as a differential diagnosis. So this is locally advanced carcinoma of the breast, LACB. See that T4B, skin involvement is B, A is chest, and C is the clubbed of that. That we will come to know only after clinical exam in the patient by falling forward and mobility of this one, because breast carcinoma breast is adherent to the breast tissue, unlike fibroadenoma, which is most independent of breast tissue. They call it breast most in the breast. So all these things you have to see: lump underneath, occupying lower quadrant, nipple areola, all those things I have told already. Chest wall involvement, axillary nodes, and metastatic workup has to be done clinically and of course evaluation wise. So evaluation is, the investigation is true-cut biopsy, true-cut biopsy, true-cut biopsy. If you want to assess, of course you have to do ultrasound. Currently mammography is a standard requirement, especially for the opposite breast. When you do ultrasound, see both breast and axilla also. Axillary lymph node, if there are palpable or sonologically it is visible, then ultrasound guided FNAC of the nodes can be done. For the primary tumor, ideal investigation is true-cut biopsy. It's very, very clear, no confusion in that. Of course, you can do the typing of that, you can do the grading, you can get the histological staging, grading, everything. And once you do a metastatic workup, you can always have staging with a clear picture, and you can plan a protocol for how exactly treat this particular patient. So that's why true-cut is ideal investigation for the primary tumor, FNAC probably for the axillary nodes. In a stage 3 disease, like a locally advanced carcinoma breast, PET-CT is the investigation of choice for metastatic workup, unlike in stage 1 and early stage 2, where PET-CT is guideline-wise not recommended, even though many oncologists practice, where you need to do a chest X-ray, chest CT, and ultrasound abdomen, liver function test, mainly enzymes, and spine, probably if required, radioisotope scan of the spine. That is also mainly for T3 lesion. Mainly chest CT, ultrasound abdomen, liver enzymes in early breast cancer. But malignancy like this, PET-CT is the choice investigation to have a metastatic workup whether bone is involved. All of you know that commonest bone is spine, in that lumbar spine and the pelvic bones. So through the Batson's plexus for the third perforators from the breast vein through the vein, third posterior intercostal vein, not perforator, third posterior intercostal vein, it drains into the Batson venous plexus where there are no walls. So there is a metastasis common in the lumbar spine and the pelvic bone. So this is the basic things you have to look into that. Now treatment, because it's LACB, neoadjuvant chemotherapy, then after 3 cycles usually, reassessment for response, then modified radical mastectomy. Here, no role of BCS, no role of breast cancer surgery because large nodules, skin involvement, and nipple areolar complex is involved. So to give a neoadjuvant, then modified radical mastectomy, usually Achin-Claus type we will do. There are 3 types, all of you know. Later continue the adjuvant chemotherapy, add on to radiotherapy if needed, and after that give 5 years hormone therapy. Radiotherapy and chemotherapy can be given clubbed together. Concurrently, it is supportive to each other. Chemotherapy helps in radiotherapy, and radiotherapy helps in radiotherapy sensitizes the chemotherapy effect. So it is sensitized with each other. Whereas hormone therapy suppresses the efficacy of the chemotherapy. So hormone therapy will not be clubbed with any of these modalities. So hormone therapy is always kept as a consecutive therapy at the end, usually for 5 years, either tamoxifen or letrozole, the 2 drugs which are commonly used. 5 years or 10 years, there are variables with the different guidelines, but commonly 5 years. You can give up to 10 years depending on the situation. Regular follow-up is needed. It's the basic thing. So you have to go through the my clinical methods in surgery for detailed examination through JP publishers, and also my SRB manual of surgery, Carcinoma breast chapter is there. Breast chapter, entire thing in detail it is given. Please go through that so they will have a clear idea how you will manage locally advanced carcinoma breast, because this is kept as a long case in the exam. You should write a proper case sheet and discuss all these things. So go through all chemotherapy regimes, taxanes, all those things. Regime is important, and radiotherapy indications, how we will treat LACB, detailed discussions is there in my book. Please go through the book to have the clear idea about that. So answer the MCQ. Letrozole is A, estrogen receptor inhibitor, B, aromatase inhibitor, C, HER2/neu inhibitor, D, vascular growth factor receptor inhibitor. Find out the right answer. I will get back to you. And another MCQ, commonest site blood spread in carcinoma breast is lungs, liver, brain, bone. Give the right answer. I'll get back to you. And quotation of the day for your understanding. What you will inhale, you will exhale. What your input will give you the output. So students, please go through my SR-based clinical methods in surgery, current edition, which gives in detail about the clinical exams, all chapters, including X-rays, other images, basic instruments, specimens, and gives a very lot of photographs are there, figures, illustrations are there for your benefit. Detailed clinical methods and case sheet rating is there. That's very important for clinical surgery. And manual of surgery, current edition, gives a detailed discussion of all topics, specialties, urology, cardiothoracic, and other chapters, including instruments, operative surgery specimens, as per CBMA syllabus in detail for your knowledge, exam, theory, clinicals, everything. Please go through that. And of course, my operative surgery book with the 2 volumes, very useful to understand the every operative procedures, the step-by-step technique, and my atlas of tissue approximation, small book with a video. All this contains a video of demonstrations of different things. It also gives a suturing technique very briefly, very nicely, and with the principles. Please kindly go through that. And my SRB surgery insights and YouTube different channels, my website. You can please subscribe. That will give a lot of information, and it will be very well benefit for all students. And please subscribe my SRB surgery insights of different modalities for understanding better knowledge and subjects, because different breast topic, different versions are there in small topics in the website, and this is the QR code for the same. So students, I hope you have understood the lecture very well. Thank you so much.